My name is Benjamin Young, and I am a gastroenterology fellow at the University of Michigan. I am also the first author of an abstract entitled, "Do Clinical Outcomes Post-ERCP with Pancreatic Duct Stenting Predict Clinical Outcomes Post-Lateral Pancreaticojejunostomy in Patients with Chronic Pancreatitis?" The idea for this topic came from discussions that were being had between gastroenterologists and surgeons with regards to determining if ERCP could be used to predict pain response in patients who underwent decompressive surgery. There was no data investigating this question, and so we decided to look into it ourselves by doing a retrospective study here at the University of Michigan, combined with results from Dartmouth-Hitchcock Medical Center and Brigham and Women's Hospital. Each center performed a chart review of their patients who had undergone ERCP with pancreatic duct stenting and subsequent lateral pancreaticojejunostomies between the years of 2002 and 2009. Patients had to have undergone successful stenting of their pancreatic duct in order to be included in the study, and all of the patients of interest were narcotic dependent. And looking through the charts in order to determine response to pain, patients who were documented as having a significant reduction in their narcotic requirement or who achieved narcotic independence within 2 months of undergoing their procedure were considered to have a clinical success, and this was the primary outcome of interest. A total of 14 patients ended up meeting criteria for inclusion in the study. And in looking at narcotic independence as an outcome, patients who achieved narcotic independence after an ERCP had a strong likelihood of achieving narcotic independence after undergoing a lateral pancreaticojejunostomy with a positive predictive value of 100% and a negative predictive value of 75%. Likewise, patients who achieved a narcotic reduction after undergoing an ERCP had a strong likelihood of achieving narcotic reduction after lateral pancreaticojejunostomy with a positive predictive value of 89% and a negative predictive value of 100%. There was no statistically significant difference between age of patients, duration of disease, presence of diabetes, or use of tobacco or alcohol, as well as findings at ERCP to include presence of stones, strictures, or pancreatic duct size. In drawing conclusions from these results, it seems that patients who do well after undergoing stenting with ERCP are likewise going to do well after undergoing a lateral pancreaticojejunostomy. Perhaps more interestingly though, what we also found is that patients who did not do well with pancreatic duct stenting after ERCP did not seem to do well after undergoing lateral pancreaticojejunostomy. This ultimately seems to suggest that we have a better idea of who might do well with surgery, but more importantly, who we should not send to surgery. Ultimately, larger prospective studies are necessary in order to validate our results. Thank you very much for your attention, and please feel free to stop by our poster at DDW for further discussion.